Hi, this is Brian Kim. I want to share with you case number 132 in the Best Way to Do Cataract Surgery series. This is a patient with an average lens density, and you're going to see double chop, cross chop, and mechanical fracturing techniques. But you're also going to see how I sense that this patient has some loose zonules. And I'm going to show you and point out to you why I feel like this patient may have loose zonules throughout the case and how I was able to manage it and be aware of it as I do each of the maneuvers of the cataract surgery. So I'm using a cotton tip to steady the eye and then using a corneal marker, which will help me to center and size the rhexis. This is my diamond blade. I'm going to make a paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, and it'll allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine. And then this is some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I get the appropriate size and length shelf, I enter. Push some more viscoelastic. This is a puncture style technique for the capsular rhexis. Puncture the center, pull down towards me. As you can see, this is an older case. I'm using older capsular rhexis forceps, my original ones, going around circumferentially, making sure I stay within the confines of the corneal mark that I made to give me a well-sized and centered rhexis. So again, nothing particularly worrisome with regards to the zonules at this point. I was able to do the capsulotomy nice and easily without any trouble. I didn't have any significant zonule laxity that I saw there. This is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, start to get a nice wave, decompress on the left side. So right here, as I'm trying to decompress, you can see the zonular laxity here. So when you're trying to decompress and you just see that the whole bag moves back and it doesn't allow that fluid to come out, that is a sign of zonular laxity. So very carefully, I'm able to turn the lens, but again, you can see that that counter traction is just not there. As I'm applying that torsional force, the zonules are not able to support the lens as well, so you see that little bit of a wobbly effect. So go ahead and lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Place the chopper under the rhexis edge contra-incisionally, the phaco tip vertically sub-incisionally, bisecting the lens in half. That's double chop, placing the chopper around the right heminucleus, hooking the lens, crushing it between the phaco tip and the instrument, the chopper, and that is cross chop. Using the chopper to hook that first quadrant up, and then emulsifying the lens piece, using the chopper to hook up that second piece, the second quadrant, and then emulsifying the lens piece. So I'm able to use a chopper to hook those two pieces up out of the bag, which is always a good thing to do when you're dealing with suspect zonules. You can see I'm very carefully and gingerly rotating the second heminucleus in front of me, placing the chopper around the lens piece, crushing the lens between the instruments, bisecting it in half, turning it a little bit more, and then I'm going to go after that quadrant, bisecting it in half again with the same maneuver, crushing the lens between the instruments. That piece is a little bit looser now. I'm able to bisect it again, and then I'm crushing it between the instruments, and then I'll emulsify the lens pieces. So when you're dealing with suspect zonules, you just want to be really gentle. Again, not to apply too much torsional stress on the zonules if you can. And you saw that I was very ginger as I was trying to rotate the lens piece within the capsular bag. If I found that I was not making any headway, I would have to come up with an alternate strategy. But I never recommend just using brute force to try to rotate the lens. It's really not a good idea. So now we're left with epinuclear material, and most of it's come out, but a lot of that is still stuck in the subincisional area, which tells you that the epinucleus is still quite adherent to the bag. So here you can see I'm using a cannula. I'm just going to pulse it under the rexus edge, and I'm trying to pulse that epinucleus and loosen the adhesion between the epinucleus and the bag here. So I switch to IA also as I do that, and I'm grabbing in the subincisional cortex, and you can see the lens epinucleus pops up. It's a little bit of a stiff piece of epinucleus, but I was able to get it out nicely there. Start to remove the cortex. Again, in these cases, you want to switch to polish mode. By switching to polish mode, it's less aggressive settings. The aspiration rate is low. Vacuum is considerably low. It's a fraction of what it is on cortex mode. And you're able to gently clean the capsular bag of the cortex and even the lens epithelial cells. You see I'm polishing in the subincisional area. And as you do this, if the posterior capsule tends to collapse into the port, that's also a sign of weak zonules. And you can see I'm very gingerly trying to clean and polish, and I'm able to kind of take my foot off of the pedal if I feel like I'm grabbing the posterior capsule, and just very gently grabbing and then re-grabbing, letting go, and then grabbing again and letting go. And I'm able to clear most of that subincisional material. And so once you feel like it's pretty clean, I go ahead and push and pulse BSS into the subincisional capsular fornix. And luckily it's really clean there, so that paid off. And so this is some cohesive viscoelastic that's going to fill the capsular bag. And then I'm going to sweep under the anterior capsule edge with the capsule sweep, first on the left side and then on the right side. I must have suspected that this patient may have weak zonules, and so I chose a 3-piece lens. So you can see I'm widening the incision and then placing the lens into the eye. Turn the bevel to the left. As the leading haptic is delivered, I make sure it goes into the capsular bag. And as the optic unfolds, I make sure I rotate my hand 90 degrees counterclockwise so the optic comes out flat. And then I dial in the trailing haptic with the Maltzman. Going in with the INA handpiece with irrigation off, activating irrigation, removing the viscoelastic underneath the lens in the capsular bag, repositing the optic back, polishing under the rexus edge a little bit more, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a fairly average lens density. You saw double chop, cross chop mechanical fracturing techniques, and I was able to crush the lens into smaller and smaller pieces using mechanical forces. By doing it this way, you're able to use much less ultrasonic energy. And you saw there's some signs of loose zonules, and when you're trying to decompress the bag, you can see that it didn't do that quite well, and the bag started to kind of push posteriorly as I was trying to decompress. That is a sign of some zonular laxity there. And you want to be very mindful and ginger as you rotate lens pieces within the bag, and use as little rotational stress on the bag as possible. You want to be able to hook lens pieces up out of the bag using the chopper rather than going after pieces with high vacuum, because when you have weak zonules, sometimes you might grab the bag itself. And as a final confirmatory point that this patient does have loose zonules, if you look at the capsulotomy, I made it round, but once this 3-piece lens came in, it does stretch the capsular bag with the haptics, and you can see the ovalization of the capsulotomy, and it's in the direction and the axis of those stria lines in the center of the optic. So thankfully this patient did well, and these are just some simple tips and signs for looking for loose zonules. So I hope this was helpful to you, and I thank you for your attention.